Welcome everyone to the PACIO and physical activity off-cycle test event. We are integrating physical activity data with personal functioning and engagement data. So we are using physical activity data as a gauge for prior level of functioning, since patients don't usually have an assessment from a therapist prior to an event. So in this case, our patient, Betsy Smith-Johnson, has been seen by an exercise physiologist and will be later assessed by an occupational therapist who will review that data. And we want to tightly integrate these two types of data. That's what we're going to be demonstrating today. So Betsy Smith-Johnson is a 65-year-old female patient recovering from breast cancer. During chemo, she met a friend who mentioned that some neighborhood fitness centers offer programs for cancer survivors to help them recover muscle mass that they may have lost during treatment. That's due to fatigue, lack of physical activity, loss of appetite, et cetera. There are a lot of reasons that you lose muscle mass and physical functioning during cancer treatment. Betsy obtains a prescription for exercise from her primary care provider, Dr. Anita Chu, and enters the program. And the program exercise physiologist enters data that is shared with her medical record. So these are observations and goals and conditions that are entered into her medical record by the exercise physiologist. So I will stop sharing my screen and we'll take a look at that data.
Okay, so we'll start showing the conditions. So these are the two physical activities conditions that were recorded by her primary care doctor, Dr. Anita Chu. So we have the fatigue condition here. So this condition is pointing to an observation previously recorded regarding Betsy fatigue. And the code here is neoplastic malignant related fatigue. We can take a look at the observation, which was just an assessment of Betsy fatigue, and measurement was 35 points, which means extreme fatigue. Next, we can show the second condition, which is the lack of physical exercise. That was also recorded by Dr. Anita Chu. And this one is pointing to ear observation strength, and noted here that frequency of muscle strengthening physical activities, it's about 0 days per week. So Betsy is not doing any strengthening activities at the moment. Is there anything else that we need to show on this one?
Yeah, if you could just show the observations, just as a group of observations. So this is collected information from multiple different sessions of guided physical activity. So this is from her exercise program. So calories burned, how she experienced the activity, her heart rate, the number of minutes of physical activity. And these are all things that other providers are currently not able to see, right? So if a therapist right now can only sort of guess based on what a patient tells them or from what's in the medical record for a level of physical ability. But what this is basically showing is this data is now going to be available to any practitioner, which is exciting. Okay, let's pop into scene one. So this is the pre-scenario situation. So Betsy's condition is improving. She's getting stronger. She's in this physical exercise program, and now she's going to have a medical event. So Betsy suffers a witnessed ischemic stroke. That is a clot in her brain, specifically in her left middle cerebral artery, but it is witnessed. And because it is witnessed, 911 is called promptly. She's taken to the hospital within 45 minutes. TPA is administered in under 2 hours. So we're in that window of treatment for an ischemic stroke, and her condition is stabilized. She sees a neurologist at the hospital. She gets imaging done at the hospital as a standard of care. She's found to have significant right arm hemiparesis, so that right arm weakness following a stroke in the middle cerebral artery, and a diagnosis of ischemic stroke is created in the system. Betsy's overall condition improves in the hospital. She's stabilized. She's released to the skilled nursing facility. And over the course of the next month between the hospital and the skilled nursing facility, her overall condition improves as her stroke symptoms begin to wane a little bit. Some of her other symptoms clear up. She also had some facial weakness, a little bit of facial drooping, and some other symptoms that clear up as part of her treatment. But she has lingering right arm weakness that's significant. And her lower body also deconditions in the hospital and in the initial part of the stay at the nursing home, because she was not as mobile due to her stroke and the care surrounding her stroke, which is not great. So she begins to decondition, and that's going to be a challenge for her later down the road. So let's take a quick look at that data, and that's going to be condition and diagnostic data. Great. So what we're seeing here is the hemiparesis diagnosis. So that's the strength in her right arm, that right upper body weakness. So this is the diagnosis and the note from the neurologist. And then the stroke diagnosis, also with the note, the small narrative from the neurologist. Now, part of what we've done here is we're providing some of the data, not the whole thing. So obviously there was a reference to a CT scan with contrast. We didn't create a resource for that. We're relying on the diagnosis resource to do the heavy lifting for us. So obviously there's more data that is accessible in this record where, if somebody wanted to take a look at those pictures or see the full narrative of what the neurologist had to say, those would be available in the medical record. But in this case, we're relying on those profiles to do the heavy lifting for this scenario. And those were the conditions created by the hospital. And as you can see in the goals have been put on hold for her physical activity, right? Because she's been hospitalized in between sessions and now she's no longer able to participate. So her doctor, Anita Chu, went back into her record and said, hey, these are on hold until you're well enough to continue your physical activity, which is going to be important in your recovery.
Oh, yeah, that's the case for all her goals, fatigue, strength, and aerobic.
That's right. And these are still the previous observations from the physical activity. So if I could share my screen again, I will go to scene 2, which is kind of a busier scene. This is where everything starts to come together. So in scene 2, Betsy's discharged home into the care of a home health agency. An occupational therapist from the home health agency is the first one to see her for her start of care. Obviously, she's going to have a large interdisciplinary care team taking care of her, maybe a nurse, maybe a physical therapist, an occupational therapist. But in our scenario, we're going to focus on the occupational therapist who sees her first. And as part of that start of care, the occupational therapist is going to go back into the medical record, and that medical record is going to have physical activity data in it. It's going to have the conditions. It's going to have the previous goals. It's going to have all the information that we've seen created up till now. And what the occupational therapist is going to be able to do with that information is let that guide their assessment. They're going to do a complete physical assessment, which is, again, the standard of care. And from there, they're able to sit down with Betsy and say, what are your priorities in recovery? And based on what I have seen from the information that's available to me, what are good goals to create for you that you have rehab potential for? What are realistic, achievable goals that we can set? And so that's what we're going to look at next in the medical record, as that information gets created. Awesome, thank you. So I'd like to call attention, we're using the ICF, that is the International Classification of Functioning and Disability code set from the World Health Organization to categorize this information. And so these codes at the top here, moving around within the home, Delta 4600, that's an ICF code, and we're really excited to be using those to categorize our information. The other observations within here are from the OASIS assessment, which is the standardized CMS assessment, which all have link codes associated with them. These are mandatory for home health agencies to use as part of their care. So we're breaking down the data and looking at the data different ways, and we can organize it different ways, and we can search and filter through it different ways using this scheme. And we're really excited to do that. So here we see that moving around the home is very difficult for Betsy. She's having trouble navigating the house. She needs assistance. She needs a lot of help getting into and out of the sitting position. So standing up, sitting down, she's not able to do that by herself. And she's also needs that touching assistance, that supervision, and a little bit of guidance in sitting up and laying down in bed so that she doesn't fall, which would obviously set her back significantly. We also see further down, she's having trouble putting on clothes and taking off clothes. She doesn't literally have her arm tied around her back. She just can't use her right arm now. And that's going to be a significant challenge, as Betsy's dominant hand is her right hand. So from there, the occupational therapist is able to create new conditions and problems and concerns, which all use very similar FHIR resources. So in addition to the stroke diagnosis, the hemiparesis diagnosis, and these are diagnoses, they have to be made by a doctor. So those are going to stay in the medical record kind of unchanged. But now the occupational therapist is able to create concerns. So that's Betsy herself. That's her health concern about her health or her functional status. And then the occupational therapist problems, which are problems that the occupational therapist has identified. So Betsy is really concerned about not being able to get herself dressed or undressed. And that is embarrassing and frustrating and is really causing her a lot of discomfort. And the occupational therapist also notes that she has that right-sided muscle weakness in her arm and her lower body is deconditioned. And so that's this functional status of her legs are no longer as functioning the way they're supposed to be, and that's just from lack of activity. Going down, we have a lot of great data in the details to support this. So these are all broken out. This is deconditioning condition here. This problem is pointing to both that personal functioning and engagement data, that OASIS data, and physical activity data. So the occupational therapist is going back in the record and saying, hey, Betsy, you were doing this vigorous exercise. You were on a treadmill. You were on an elliptical. You were doing all of these things for up to 150 minutes a week, which is the recommended amount. And now you're having trouble walking around in your home. So that's the supporting evidence there where we're saying that wasn't her prior level of functioning was much more robust than it is now. And that's such a helpful guide marker for clinicians, right? Because otherwise we're sort of left guessing. From there, yeah, absolutely. If you could take us to goals. So in the goals, now if we could take us down to occupational therapy goals. Perfect. Great. So now we have the home health agency dressing goal. So this is the occupational therapist sitting down with Betsy, and we really believe that a patient's priorities need to be captured as well, right? And so this goal is a personal goal for Betsy. Betsy wants to get back to the way she was, in that she wants to be able to dress herself and undress herself. She doesn't want to need help with those activities. And the occupational therapist is pointing to these concerns and these observations that she has made during the assessment, showing that Betsy's functionally having trouble with these, but also that they're related to her primary diagnosis. If we could go back to goals again. Perfect. And then that standing and walking goal, again, Betsy's lower body is deconditioned from a lack of physical activity, and the observations that were made during her assessment are the foundation for setting these new goals. But the occupational therapist is also able, using that physical activity data as a guide, to say, you know, you were getting better. Your functional ability was getting better just a month and a half ago. You are on your way to recovering some of what you lost during this cancer treatment. And that means you have a great rehab potential for this functional mobility and moving around and standing up and walking around again because you did it before. And so that becomes a realistic goal based on that prior functioning data, which is really exciting. So at the conclusion of this occupational therapist appointment, Betsy begins her therapy again. She gets put on a plan. The therapist creates a plan of therapy, plan of care, and 3 days a week, she will be making visits. After that, Dr. Chu renews the prescription for physical activity because the exercise physiologist can come to the home and supplement the occupational, physical, and speech language therapy with exercise and physical activity. That is something that is available to Betsy. And so now the goal is reestablished. So now there's a new 12-week exercise program that exercise physiologists can work off of, and they're going to pick right back up with their goals of getting Betsy up to that 150 minutes a week of moderate to vigorous aerobic physical activity. So the exercise physiologist comes in, reestablishes the previous goals of care, but now also has goals related to the observations and problems and conditions that were made in her medical record in the interim month and a half since they've last seen one another. So Betsy's condition has changed. She now has new problems and diagnoses. She has other providers coming in and making observations about her functional ability. And the exercise physiologist is able to see that. And instead of duplicating effort or doing something that Betsy's not ready for, or doing something that may set Betsy back otherwise, so either overexerting Betsy in a way that keeps her from achieving her therapy, when the therapist comes in, they can make a plan that is complementary. And this is so important. And we see here in this goal that it addresses a condition set forth by the occupational therapist. As a note, there was a typo in the data, not a big deal. It's pointing to one of the other PFE resources. But what we are demonstrating here is that these two IGs do work together and they do point to one another seamlessly, which is what we wanted to begin with. So instead of her right arm and shoulder weakness, it would be that deconditioned problem. But what it is showing is that they play nicely together, that the PFE and PA IGs play well together. And they do bounce around here down in the details, in the addresses, in the evidence, data elements. We've really pointed these resources toward one another where we could. And so there are a lot of internal references between these data. And there's a lot of richness there that these different providers can see. And so Betsy now has a month where she's able to receive this exercise support in her home, the therapy in her home. And at a future time, we hope to be able to show her reassessment data. But here, what we've really achieved here is showing that these two IGs not only point to one another and work together seamlessly, they're showing the right providers the right information to support decision-making and to really inform care and to line up that therapy with Betsy's personal goals of care, which is really important. Thank you all very much.